following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, ALS and Parkinson's disease. Two experts are here to answer your questions. Now here's your host, Dr. Raleigh Sullivan.
Good evening. ALS is amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. About 5,000 new cases of ALS are diagnosed every year in this country. New cases of Parkinson's disease are diagnosed in about 50,000 people each year, and is slightly more common in men than in women. So what are the symptoms of these problems? How are they diagnosed and how are they treated? Where can you go for help? We'll get answers to those questions and more tonight from our two guests. Dr. Lori Gutman, a neurologist at WVU, whose special interests include neuromuscular diseases, and Dr. Catherine Budafish, also a neurologist at WVU, whose special interests include movement disorders like Parkinson's. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. And so, Lori, I'm going to start with you. ALS is a devastating disease that leads to muscle weakness and I think eventually paralysis and all sorts of bad things.
It's in the world of neuromuscular diseases, it is one of the most difficult diseases because it starts out with weakness that seems relatively mild and then can progress over a period of 3 to 6 years on average, to the point where people are bedridden, need help with their breathing, maybe not being able to swallow. And it is a very difficult disease for not just the patient, but the family. As a neurologist, it's one of the harder diseases for us to treat.
Before I get Catherine into this, what ages are we looking at when this starts?
Average age of onset is usually in the 30s, 40s, although it can occur much younger and occur much older. But that's the other thing that's difficult about this disease, is that it seems to be occurs in people in the prime of their life. In
the prime of their life. You said 3-6 years. Obviously, we need to talk some more about that. But Catherine, I have to get you into this. I think most people think of Parkinson's disease as the disease that causes lots of, uncontrollable tremors and twitching, I guess.
Yeah, that's correct. So most people associate tremor with Parkinson's disease, but there are more symptoms to it than just tremor, and that's really important to emphasize. So in Parkinson's disease, it's not only tremor, but you have the slowness of movement, that's called bradykinesia, and you have rigidity, muscle stiffness, and you have difficulties with your dexterity. And these are the motor symptoms that we see in Parkinson's disease. And that's, for example, very different from a disease that looks, on the first glance, very similar, which is essential tremor. And that is a disease that is basically just a tremor. And the tremor in Parkinson's disease and essential tremor is also different. So in Parkinson's disease, we have this resting tremor, whereas in essential tremor, we have an action postural tremor. So it's important to differentiate these type of tremors and to make a correct diagnosis of Parkinson's disease. And it's a progressive disease. And there are even Parkinson's disease patients without a tremor. So you don't have to have tremor to have Parkinson's disease. And there are also, just to emphasize, there are also what we call non-motor symptoms of Parkinson's disease, such as depression and some cognitive problems.
I definitely want to get into talking about that, because I know that's a big issue.
It is.
We have our first caller. This is Lita from Hampshire County. Lita, welcome to Doctors on Call. You have a question for us?
Yes, I do. My husband has Parkinson's, and he has the tremors, and they have just started him on Primidone, and it doesn't seem to be helping very much. He takes the levodopa carbidopa. Is there another medication he should be able to try?
Well, did you say Primidone? He was started on Primidone?
That's what it sounds
Yeah,
like.
Primidone.
Yeah, it's a little bit. Primidone is usually used to treat essential tremor and not Parkinson's disease tremor, and carbidopa levodopa is used to treat Parkinson's disease. So I'm not clear whether he may have both. That may be the underlying reason he's getting these two different medication. When you think about essential tremor, it's a common disease, and Parkinson's disease is a common disease, and it's not that rare that patients have both, the essential tremor and the Parkinson's disease, and then it's important to recognize this and treat both diseases.
I think it's a good question. So how do you, as physicians, how do you diagnose, which one they have?
Yeah, it is a clinical diagnosis. So there's not a single test you can do to confirm that. So no blood test in general. Let's say in general there's some genetic testing, but in general there's no test that you can do, no imaging of the brain. It's just to confirm and rule out other possibilities. But it's based on your clinical exam and your history. So I mentioned it before, there are different types of tremor. So essential tremor is an action tremor, meaning if you take let's say a mug and
so
drink,
if you try to pick up this?
Yeah, if you take the essential tremor comes out with action, so by picking it up and trying to drink. Whereas in Parkinson's disease, it's a resting tremor, so it occurs at rest, with the body parts at rest. So they basically just sit, and as they pick up their arms and do stuff, it goes away.
So a Parkinson's patient might pick up the cup and
they're
hold
fine.
it steady.
They may. I mean, it's not that strict, and it runs into each other, especially as a disease progresses, a Parkinson's disease. But it's based on what I just mentioned before. Parkinson's disease, you have to have more than just tremor to make a diagnosis of Parkinson's disease. You have to have at least three symptoms, like the tremor is a symptom, or the slowness of the movement, or the rigidity, to make 3 symptoms to make this diagnosis.
Slow movement. In ALS, I want to get back to amyotrophic lateral sclerosis. What's the movement like in that disorder?
The problem in ALS is that the patients just get weaker. So we sometimes see patients come to us with a question of tremor, though, and the diagnosis may be, does this patient have Parkinson's disease? And actually what you see is the tremor is actually the muscle twitching. As you start to lose the nerve input to the muscle, you get what's called a fasciculation or twitching. And if it starts in a hand, which isn't uncommon, you may see some twitching, and it's a little bit of looks like a tremor in the hand. So patients may come with a tremor in their hand, and then you find weakness in the hand, which is very different from Parkinson's disease, where there isn't really weakness. And so the thing that's specific about the weakness is it's usually painless, and there's no numbness with it. There's no tingling with it. It's just a weakness, and it's slowly progressive. So there isn't a true movement disorder. It's not a movement disorder like Parkinson's disease.
But you say sometimes people are referred who think they have Parkinson's disease, and it turns out they have ALS.
And the other way around, actually, too. There have been times where patients will be referred for Parkinson's disease because of some difficulty with movement. ALS not only causes weakness because of, ALS can cause weakness in 2 different ways. We think about the nervous system as being the central nervous system and the peripheral nervous system, and ALS involves both. And so when you have weakness from the peripheral nervous system, you get that twitching that we talked about and the loss of muscle mass and weakness. When the central nervous system gets involved, sometimes you can get some slowness of movement, some rigidity, just like a Parkinson's patient. And if the disease starts with that central part coming first, because it can present in either way. They may present with an abnormal walk, and because of the stiffness of their walking, and they may come as a question of Parkinson's disease and turn out to have ALS.
Really? Now, ALS, let me get back. What's the average onset of Parkinson's disease? What are the ages?
It's clearly a disease of the elderly in general.
Elderly.
Yeah. But there's a disease, it may start as early as 25 years or 30 years, and that's usually this young onset Parkinson's disease, and that's inherited more often to be found and to be inherited.
Really?
Yep.
I didn't realize that Parkinson's disease was sometimes inherited. So younger age of onset, it's more likely to be running in the family than someplace.
Right. You can find this, there's a mutation that you can find more often in these patients with young onset Parkinson's.
Is it more severe if you get it when you're young?
Well, there are different courses, I should say. I mean, some do progress rapidly, but some don't. So it's as we learn more about Parkinson's disease, we learn that there are really different courses.
Really?
Some more rapidly progressing, and some do very well. Some develop a lot of complications from treatment, as the disease progresses. Some don't. So it's probably not one Parkinson's. Parkinson's has different courses.
That's similar in ALS. I'd say, in ALS, some patients will, the average lifespan for someone diagnosed with ALS is 3 to 6 years after diagnosis, but it can be extremely variable. Some patients have a very rapid course. Others we follow in the clinic 10 years, 11 years, 12 years, and you often hear about the people who live much longer than that. So it's the thing about both of these diseases, as they're diseases where the nervous system is slowly degenerating or breaking down, and cells are dying, it's, we see the outcome of it, but what causes the disease and causes all these different courses may still be very different subtypes within a major category. Wouldn't you say that's right?
Yeah.
Let's, I encourage anybody in the audience who has a question about ALS or Parkinson's disease to give us a call. Our phone lines are open. I want to ask both of you, though, but actually ALS is 3 to 6 years, you said. That's a fairly rapid, progression. And the progression in Parkinson's disease can be...
Oh, can be a very long-lasting disease. I mean, we have patients 45 years out after the onset of their disease, and in general, people do very well for the first, let's say, 7 years or so.
7 years.
7 years is the average when they start to develop problems related to the treatment. It's not necessarily a side effect of the medication, but it's a problem with. It's a progressive disease, and its underlying problem is that the neurons in the substantia nigra pars compacta, so it's a structure deep in the brain that produces a dopamine, and they die. And it's very fascinating. About 75% of those neurons have to die before you develop symptoms.
Even start to get the symptoms.
Right, before they become apparent.
Well, I want to get back. I want to ask both of you about running a clinic for, these sort of. Actually, one of them is a very prolonged degenerative disease and ALS, but we have another caller. It's Joanne from Hancock County, I believe. Joanne, welcome to Doctors on Call. You have a question for us?
Yes, I do.
Okay.
I'm a home health aide, and I take care of a 79-year-old woman that has Parkinson's. I get there at 7 o'clock in the morning, and it takes me till 7:45 to wake her up. Is there something else I can do besides shaking her and yelling her name to wake her up? Is that part of the disease, or is that just the medication?
Wow. Do you know what medication she's on?
She's on most of the ones that this doctor mentioned a little bit ago when the other person asked a question about Parkinson's. She takes the carbidopa, levodopa, and the other medicine that she mentioned. I don't remember the name. And she takes 5 or 6 different kinds of medicines 5 or 6 times a day.
Okay, so other things too.
Yes.
All right.
Well, difficulty in arousal or waking somebody up is not really a typical feature that we see in Parkinson's disease. What you usually see in the morning is that they're rather stiff and difficult. They have difficulties moving, but they are up, they are alert, and they wake up. So I'm not sure whether this is a side effect of medication that your patient is taking. That needs to be looked at.
Yeah, it sounded like she was on 5 or 6 other meds too, and there are a lot of things, of course, that could cause excessive drowsiness.
Yeah, I mean, yeah.
I guess getting her to, one of the things that the health aide could do is mention this to the patient's doctor, and maybe they could take a look at the medicines. You know, it sounds pretty severe, 45 minutes to try to wake her up every morning.
The other possibility is sometimes what happens that Parkinson's disease patients don't rest very well, because what happens is that they wear off. So the medicine, they take the last tablet, let's say, when they go to bed, last tablet of the carbidopa, levodopa, and that usually carries them a couple of hours into the night, and then it wears off. But you have to remember that in order to have a good quality of sleep, you tend to turn in bed, and oftentimes Parkinson's disease patients have a hard time turning in bed because they're so stiff and they're rather very uncomfortable. So another possibility is that she just doesn't rest very well and is in deep sleep in the morning when she's supposed to wake up.
Before I get to the next caller, is that a general problem for Parkinson's disease to have sleep problems, or even, and I want to get you back into it, also ALS or sleep disorders?
Oh, sleep disorders is a big problem in Parkinson's.
It is, it's a big problem.
Oh yeah, they have all kinds. There's a higher incidence in different type of sleep disorders.
In Parkinson's?
In Parkinson's
In
disease,
ALS, the problem with sleep is that patients often can get very similar to sleep apnea problems.
Really?
It's not true sleep apnea. What happens is when they lie down, because they may have some weakness of the respiratory muscles, and when you lie down, gravity is no longer helping you with your breathing. It actually is pushing down on you. So patients sometimes may not rest well. They may wake up feeling very tired or have headaches. And what you have to watch is if they're we watch very closely with their breathing, and that goes back to what we were starting to talk about earlier about other people helping us take care of these patients. Other disciplines, helping us take care of these patients because of the breathing. And then we use what's called non-invasive positive pressure ventilation, which is the same thing as BiPAP or CPAP that people use for sleep apnea, can really help ALS patients sleep better. And without that, they're extremely fatigued and tired, and you add that on top of progressive muscle weakness, it can really be devastating.
We're going to get back. We're going to talk about the clinic here in a minute because I really want to do this. But I want to get, this is Betty from Mason County. I want to get Betty on the show. Do you have a question for us?
Yes. I've had Parkinson's about 13 years. They've got me on 1 1/4 Centimet from 11.5 pills. And then from 10 o'clock, they got me on 1/5200 Centimet, and at 3 o'clock, another one. I'm stiff. My head feels like it's busting. I can't hardly move at times. This morning, I woke up and couldn't move an arm or a muscle or anything else. But the doctor won't increase my medicine. That's the only thing I'm on. Is there anything else I can get on?
How old are you?
I'm 67.
Okay.
How much carbidopa levodopa do you take? I didn't get that.
11.5 pills.
11.5
pills.
1 to 4 every 2 hours.
You said you have Parkinson's disease for 13 years now.
Yeah.
So that is a range where you get into these problems with medication not lasting that long. So even if you take your carbidopa, levodopa, it may last only or carry you only for maybe an hour, 2 hours, and then you wear off and you have to take the next medication. So one question is whether you need to space the medication more closely to prevent this wearing off. And then the other question is whether you take enough of it. And then oftentimes what you have to think about is whether you need some additional treatment, and a more recent treatment that becomes available or became available is surgery, deep brain stimulation. So these are all possibilities one has to really evaluate by sitting down and going over.
Let's talk briefly before we go to the next caller about what it's like to manage patients with these disorders over a long period of time, because we've talked about some medications, but there's other things that could be helpful for people.
Yeah, I think both Catherine and I have discovered in our own, in our fields, and I think it's been going on in ALS a little bit longer than in Parkinson's disease. People who care for these patients find that if you approach the patient with a multidisciplinary or an interdisciplinary approach, so you have multiple physicians and therapists, social workers, psychologists, all work together taking care of the same patient as a team, you can oftentimes help quality of life much more than we ever used to be able to. And actually in ALS, the literature shows that patients live longer and they have a better quality of life if people use a multidisciplinary approach. So many of these clinics will have for the ALS clinic, we'll have pulmonary doctors or respiratory therapists who are involved, speech therapists, physical therapists, social workers, occupational therapists. The nutritionists are very important for the ALS patients. And what happens is then the patient actually has a whole team repository, so they can call, there's a problem, there's a whole team that already knows them and can advise people in the community too, which is very important because many patients who go to see a specialist don't live very close to that specialist, and it makes it a little bit hard. Your experience is similar, right?
Yeah, I have a similar experience. So we work with OT and physical therapists.
Occupational therapy.
I'm sorry, occupational therapists and physical therapist and social worker and a speech pathologist. Oftentimes, a little bit like in ALS, we have in Parkinson's disease, there's a slowness of movement that also affects the swallowing and the speech. And so they are oftentimes difficult to understand, and they at times aspirate. So it's an issue. So we have a speech pathologist, and that's also, and then a very important person in the team is actually our neuropsychologist and psychiatrist.
Neuropsychologist, all right.
Yeah, oftentimes underdiagnosed in Parkinson's disease is depression.
Is depression, yes.
Depression may even precede Parkinson's disease. It's very prevalent and has been shown to be one of the symptoms that if you control it, has a big impact in the quality
Controlling
of
depression.
Yes.
I wish we had more time. I want to get our next caller in here, but there's all sorts of things I'd like to ask you all about that. Next caller is Pollyanna from Fayette County. Pollyanna, welcome to Doctors on Call. You have a question for us?
Yes, I did, and you had I'm a good segue. I had a question about ALS, Parkinson's, and Alzheimer's.
Okay.
In these neurological diseases, is aspiration a big problem, and how so can you deal with it?
Wow.
Yeah. Aspiration for ALS patients is a problem for...
You might describe what aspiration is.
Okay,
yeah.
so aspiration is, when aspiration, it can be either when something in your mouth goes down the wrong tube, okay? I mean, that's kind of a simple way to say it, but it can be your own saliva. Sometimes patients have problems just handling their own saliva, their own spit. You can't swallow it very well in ALS. Like I said before, it could be the peripheral problem where it's the weakness, or it could be the central problem where the function just is a little stiffer, and sometimes somewhat similar to what happens in Parkinson's disease. And the issue is that if you do have aspiration, you're at risk to get pneumonia.
Yes.
And so even if in ALS, sometimes patients no longer eat by mouth, and they get a tube put in their stomach if they're having that much trouble swallowing, but you still have to worry about just handling like I said, their own saliva.
We have about 1 minute left, so what would you like to tell the families out there and patients about Parkinson's disease and ALS?
I think one thing I would like to say is that, for both of these diseases, the approach now is really not just trying to treat the patient, but you have to not just trying to treat the patient's disease, but treating the whole patient, as well as helping the caregivers and helping the community physicians, the community itself, because it care for the patient, because it becomes more than just a physician giving a pill, because that's not very successful in either of these diseases. And that they should think a little bit outside the box of, getting the diagnosis and then not just relying only on the pills.
Excellent. I'm glad you said that. Well, listen, we've been talking about ALS and Parkinson's disease with Dr. Lori Gutman and Dr. Catherine Budafish. Thank you both for being with us. If you'd like more information, see your family doctor or visit our website at wvuhealth.com. For Doctors on Call, I'm Dr. Raleigh Sullivan. Good night and good health.
Join us again next week for another edition of Doctors on Call. Our topic will be prostate problems. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.